Okay. Hello everyone. Welcome to my lecture streaming. My name is Junji Tagami. I'm talking from Tokyo. The time in Tokyo is now 8 p.m. And today I will uh, talk about my favorite uh, topic, that is the adhesive dentistry. I am 67 years old now. 2 years ago, I retired from the university, Tokyo Medical and Dental University, because of the regulation of the age for the faculty members. Even after the retirement, I still work in the private clinic, and I hope you can visit the website of our clinic. Unfortunately, most of the pages are in Japanese, but you can enjoy many kind of clinical cases of my clinic. And um, after my graduation from the dental school in 1980, for 40 years, I uh, I worked for the adhesive dentistry in research and clinic mainly. So I'm very happy to talk about my favorite topic today. And this clinical case is the so-called kind of direct crown restoration. And this is the so-called direct bridge restoration with the composite resin restoration in direct techniques. The term of direct crown and direct bridge are now accepted by a Japanese academic dental society already. So, and we already have some clinical evaluation report of these um, direct crown restoration and the direct bridge restorations. So regarding to these treatment procedures and the clinical results will be provided in my next lecture next week. So today I will talk about adhesive material and the fundamental of the adhesive restoration. Understanding the fundamental of the adhesive dentistry is very important to apply this kind of advanced uh, clinical treatment with the adhesive material. The adhesive dentistry was started by the achievement of Dr. Takao Fusayama. He was my teacher, and in 1980 he published the very excellent book. The title was New Concept in Operative Dentistry. In his book, he established the original minimally invasive caries treatment, utilizing the so-called caries detecting dye solution and also the first adhesive resin material, that is the Clearfield bond system F, consisted of the phosphoric acid etchant to both enamel and dentin and chemical cure type of dental adhesive, and also chemical cure type of the composite resin. So at first, I'd like to summarize the difference between the conventional restoration and the adhesive restoration. In the case of the treatment of this kind of caries region, when we did not have the adhesive materials, we needed to cut the intact dentin for the retention of the restoration. That is like this. Because of the cutting of the intact dentin a lot, unfortunately, sometimes the patient suffered from the post-operative tooth sensitivity. Some of the cases needed the endo treatment after the restoration. And also, this kind of restoration was often fallen off. However, in the case of adhesive restoration, we just remove only the outer caries region, that is, caries infected region, and immediately after that, we apply the direct bonding restoration like this. It's a big difference between these two types of the restorative treatment. More than 20 years ago, we had a big movement to encourage the minimal intervention in the restorative treatment, because in the past time many of the patients suffered from this kind of very bad cycle of the restoration. Once people had the small restoration like amalgam restoration, because of the recurrent caries, the restoration becomes bigger and bigger, and someday they needed the endo treatment. And then because of the root fracture or other kind of problems, people tended to lose their teeth. To cut this very bad cycle of the restoration, the so-called minimal intervention was strongly recommended by the committee of FDI. Nowadays, because of the excellent adhesive material and the composite resin material, even for this kind of endo-treated teeth, we can apply the direct composite restoration. Okay. I was so lucky because immediately after my graduation, I could use the adhesive material in my clinic. This was my very old patient. I placed this restoration 40 years ago. Of course, at that time, the bonding performance was very low, and the composite resin was the chemical cure type. However, the restoration can survive for such a very long period. You can see that at the time, the adhesive resin material I used was shown here. The bond strength to dentin was 2 megapascal only. It's much lower than the recent adhesive resin materials. Of course, there can be seen slight marginal discoloration of the restoration, but this is not a serious problem in the clinical situation. My very good friend, Professor Kubo at Nagasaki University, he published many papers on the survival rates of the restorations, comparing between the direct composite restorations and cast metal inlay restorations. The results is very clear. After 10 years, the total survival rate of composite resin was 71%, and the cast metal inlay restoration was 76%. Also, after 20 years, the composite resin restoration showed 62% of the survival rate, and cast metal inlay showed 57%. The conclusion of his study was both of them the same. So at the time, of course, many people believed that the cast metal, precious metal restoration must be the best. However, even with the very old composite resin materials, the clinical performance was comparable to those kind of metal restorations. This is one of his clinical case. This is immediately after the restoration. It was in 1983. After 15 years, you can see some slight marginal discoloration and the surface porosity, because the composite resin had to be mixed together because it was the chemical cure type, not the light cure type composite. And this is after 20 years. Still okay. And after 25 years, the surface was repolished. By repolishing or refurbishing, this old restoration can be renewed like this. Again, we can expect another 25 years of the clinical performance. Some people are concerning about the wear, occlusal wear of the composite resin material. Of course, composite resin is worn out, attrited. However, you can compare the shape of the tooth itself between the tooth in 1983 and after 25 years. The shape of the tooth was very much changed because of the wear. Like this, the natural tooth is attrited and the shape of the occlusal surface is changed. If you apply a very hard material like the recent zirconia material, the zirconia cannot be attrited. That is the problem. So from that kind of viewpoint, I believe that the resin composite material is very excellent restorative material showing a very good harmonization with the natural tooth. Recently, there are many kind of tooth colored restoration, including CAD/CAM systems. This is the case of my new patient complaining about the tooth sensitivity and pain after this restoration. So, unfortunately, I needed to apply the endo treatment because of the pulpitis. I cut down this restoration and I confirmed that a lot of intact dentin was cut. Because of the cutting of the intact dentin, the pulp tissue had influenced. So that's why it showed some kind of inflammation. This is the side effect of the cutting of the intact dentin. This is my case after the removal of the outer caries region, after the removal of the caries infected dentin region. Of course, the remaining dentin surface does not look so clean, but this is the typical appearance of the caries affected dentin. In other words, inner caries dentin. Then we can apply the direct composite restoration onto this. This is a really minimally invasive approach in cavity preparation and removal of caries, and by a very good bonding and sealing of the cavity, we can protect the pulp. Then it must be very effective to save this tooth. So I will talk about a very important issue regarding to the caries removal. The caries is very difficult to understand because even from this kind of specimen, nobody can tell which part of caries to be removed. It is very difficult. So let's think about the caries progress. This is the dentinal tubule, and this side is the enamel dentin junction. This side is the pulp. Then at first the bacteria came into the tooth structure. This is enamel dentin junction, and invaded bacteria produce the acid. The acid can penetrate much deeper into dentin. So that's why this part, the demineralization occurs. Because of the demineralization of the dentin, the phosphate ion and the calcium ion are produced and they came into the dentinal tubules. The concentration of calcium ion and phosphate ion become more than the saturation level. So that's why those ions create the mineral crystal in the tubules. The crystal precipitation occlude the dentinal tubules like this. This phenomenon is repeated and going into deeper and deeper of the dentin like this. Because of this kind of um, structural change and the demineralizations, the noob hardness number of this part is lower than that of the intact dentin hardness. This is a dentin hardness number in intact dentin, and this is the dentin hardness number at the caries affected dentin, inner caries dentin, because this part of dentin is demineralized. However, there is no bacterial invasion here because bacteria, the size of bacteria is much bigger than acid itself. So that's why we call this layer as caries infected dentin. In other words, outer caries dentin. In the clinical situation, we cannot detect the bacteria by our naked eye. Even with our clinical microscope, we cannot see the bacteria. However, if you apply the caries detecting dye solution, the dye solution can stain this part, including the caries infected dentin. But it does not stain the caries affected dentin. So that's why, according to the guidance of this caries detecting dye solution, we can remove only this part. When we think about the tooth sensitivity, pain of the patient, if you cut this part, because of the movement of the fluid in the tubules, the patient must feel pain. That's why we can tell this part as sensitive dentin. On the other hand, this part, the tubules are occluded with a mineral deposit. Even if you cut this part, the movement of the fluid in the tubules were not caused so much. That's why the patient does not feel so much sensitivity. In most of the cases, we can remove the outer caries region without the shot of Zirocane. Now you can see in the clinical situation, sometimes this caries affected dentin looks transparent. That's why this part is said as a transparent dentin. And we intend to preserve this transparent dentin as a barrier of the bacterial invasion and stimulation to the pulp tissue. So we can reflect the information onto this photo. The bacterial invasion front may be located like this. And if you apply the dye solution, caries staining dye solution is located like this. It is a little bit deeper than the bacterial invasion front. However, the softening front, dentin softening front is located at much deeper part because the acid produced by bacteria can penetrate much deeper in dentin. That's why at the deeper part of dentin, this part is demineralized. Because of the demineralization and the reprecipitation of the mineral crystals, the transparent dentin is created. Also, in the pulpal wall side, the reparative dentin is created. This transparent dentin and the reparative dentin formation is a very excellent natural defense system of the pulp. We should not remove this transparent dentin. Then we remove this part and apply the restoration. It's very simple and a very excellent technique. This is my very old case of a young patient. You can see the caries at the occlusal area. It was very old case of mine. In 1996, I did it. I opened the cavity with a high-speed cutting. Then you can see the caries region. The caries region already had the remarkable natural discoloration. Of course, you can remove this caries region according to the natural discoloration. However, in this case, when I apply the dye solution, the area stained by dye solution was a little bit wider, bigger than that of the natural discoloration area. Then I removed this discolored dentin and the stained dentin with a slow speed steel ball. This is after the removal of the outer caries dentin, and the bottom of the cavity looks slightly discolored. But again, I can say that this is a typical appearance of the caries affected dentin. And also in this case, the cavity looks very deep and very close to the pulp tissue. Then you may be so comfortable to apply the lining material before the composite restoration. Okay, but I don't apply the lining material. I will show you why we don't need the lining. This is the extracted molar with big cavity. At first, the occlusal area is removed and flattened, and also the root was removed. Here, there still exists some part of the pulp chamber. In the pulp chamber, I filled a red dye solution, and the pulp chamber was connected with a syringe to be able to apply the pressure from the pulpal side. This is the occlusal view of the same specimen. This caries region should be removed before the restoration in the clinical situation. I removed this caries region and I put a pressure from the pulpal side to squeeze the red dye solution. Now you can see that. Here you can see the red dye solution infiltrated from the pulp chamber through the dentinal tubules. But in the area of the caries region, after the removal of outer caries region, there is no fluid comes up, this part and this part. This is because the bottom of this dentin surface, the transparent dentin must exist. That's why the dentinal tubules were occluded, plugged. That's why the connection between the cavity floor dentin and the pulp chamber is not seen at the caries region. So that's why if you wish to apply the lining material, you should apply it onto this permeable area, intact dentin. But in my cavity preparation, I did not cut the intact dentin. I did not expose the intact dentin at all. That's why in my cavity preparation, I don't need the lining material. So we can move on to the direct composite restoration. It's very simple and easy, very excellent restoration. Now I can see you the schematic diagram of the cut surface of this case. Now my cavity preparation was like this. Of course, the shape of the pulp chamber must be like this before the caries progress. But because of the caries progress, the pulp chamber becomes smaller because of the reparative dentin formation. If you like to apply the CAD/CAM restoration or the cast restoration or ceramic restoration, I mean the indirect restoration technique, you may need to cut like this. By cutting this kind of shape, you have to cut the intact dentin. That is very risky to the pulp tissue. You must need the shot of zero cane. And even after the restoration, some of your patients may complain about the post-operative sensitivity of the tooth. Okay, this is another specimen. You can see that this is the cervical caries. At the bottom of this cavity, the transparent dentin is created and also reparative dentin is created. In this case, the cavity preparation, the shape is like this. And this is the SEM of the intact dentin surface after the phosphoric acid etching. The SEM looks like very excellent for bonding. However, this is not good for the patient. The dentin cavity floor is permeable to the pulp tissue. And also because of the open dentinal tubules, the bonded surface will be contaminated with the dentinal fluid. The fluid contamination may decrease the bonding. On the other hand, this is the dentin surface after the phosphoric acid etching, but this is the caries affected dentin. Even after the phosphoric acid etching, the mineral deposition in the tubules were still remained, occluding the tubules. So that's why we can obtain very good bonding, and the patient does not have the postoperative sensitivity. Then this part, when I cut this specimen, you can see this kind of mineral crystal deposition in the dentinal tubules. It's a very excellent performance of the natural tooth. Okay, this is the publication in the Journal of American Dental Association, and in this clinical report, the after the posterior restorations, the postoperative hypersensitivity was compared between the glass ionomer lining and without lining procedures. Okay, 28 clinicians were involved in this clinical survey, and total number of the patient was 341. In this study, the Clearfield SE bond, this is one of the most reliable adhesive resin material, consisted of the self-etching primer and the light cure bonding resin. The result was very simple. Resin modified glass ionomer cement lining did not decrease the post-operative tooth sensitivity. That's why the author of the paper recommended us not to apply the lining material. In the case of the adhesive restoration using this kind of excellent adhesives, we don't need the lining material. So this is the big difference between the adhesive restoration and the non-adhesive restoration. Now I can say that the most of the reasons for the postoperative sensitivity is overcutting of the sound dentin. Now I hope you can reduce the prevalence of the postoperative tooth sensitivity after the restoration. Okay, but in the clinical situation, we can see a lot of cases of very deep caries Of course, in this kind of deep caries region, if we remove all the caries infected dentin, um, frequently we see the pulp exposures. In that case, it's a very complicated it will be a very complicated treatment in the clinic. So in the case of this kind of very deep caries region, sometimes the so-called the stepwise excavation technique is recommended. Of course, in the United States, Dr. Matt Fairhurst reported an excellent paper regarding the sealed restoration technique. Sealed restoration technique is to intentionally uh, leave the caries infected dentin, and the cavity was sealed by the adhesive restoration. Even after 10 years, the clinical cases showed a very good performance. No uh, pulpal irritation or no extended caries region. So that's why that good sealing of the cavity is very important even when we leave some kind of infected caries regions. In this stepwise excavation technique, at first we leave some amount of the caries infected dentin, and we apply the temporary filling first. Then after 3 months or 6 months, we re-entry again, and we remove the temporary cement, and we remove the caries infected dentin. At that time, the uh, reparative dentin formation is seen. That's why we could complete the removal of caries infected dentin. Then we can move on to the final restoration. So in this kind of publications, the stepwise excavation technique showed better result than non-selective caries removal. That is the complete removal of the caries dentin. The pulp exposure rate was much higher with the non-selective, non-stepwise excavation technique. If you try to remove all the caries the region, in the case of deep caries, you may see more pulp exposure. So that's why they recommend to apply the stepwise excavation technique. In Japan, also this stepwise excavation technique like procedure is recommended by the conservative dentistry society. After the removal of the caries region and leaving some amount of the infected caries region, and we apply the temporary filling material. Then after that we do the re-entry, and after the removal of the caries infected dentin, and apply the final restoration. But sometimes the patient did not come for the re-entry appointment, and also sometimes this temporary sealing does not work so well. That's why on the occasion or at the occasion of the re-entry appointment, the caries was very much developed, and the result is sometimes very miserable. So that's why in this paper they compared two groups. That is the so-called stepwise technique, and another group is stepwise technique like technique, but they did not provide the re-entry. They just applied the final restoration with some amount of the infected caries lesion. the result was um, very excellent. Without the reentry procedures, the survival rate, success rate was 80%. 80%. On the other hand, stepwise technique showed much worse result. So now we are very happy. We are very much encouraged with this kind of publications that we can leave some amount of the caries infected dentine, but we should apply the very good sealing restoration with adhesive material. This is our our papers, and in this research we analyze the relationship between the depth of caries region and incidence of the endodontic treatment after 2 years of the composite resin fillings. The depth of the caries region was determined like this by the X-ray image. Uh, this A is the surface of the tooth and B is the bottom of the caries region. AB is the depth of the region and C is the purple wall in the X-ray image. So this AB per AC, its percentage was the designated as the cavity region size. Okay, then this is the result. When the cavity depth is less than 80% of the total dentin thickness to the pulp wall, less than 80%, most of the cases did not have the endo treatment after 2 years. But in the case when the region depth was 80% to 89%, this group, the 10% of the case required the endo treatment. In the case when the region depth was 90%, very deep, very close to the pulp wall, 27% of the case needed the endo treatment. In total, more than 80% of the region depth. The 14% of the cases requires the endo treatment in 2 years. So that's why in the case of the very deep caries region, we do not remove all of the caries infected dentin. We can leave the infected caries region and apply the composite resin restoration. Then we can follow up. If the patient has some problem after the restoration, at that time we can move on to the stepwise technique or the endo treatment. In the case of the composite resin restoration, it is not so difficult. We can very easily access to the pulp. Okay. Now, the sealing of the cavity is very important. Okay, even when we leave some kind of the infected caries region, the sealing is very important to stop the progress of caries underneath of the restoration. Okay, to obtain good sealing, we have to select the reliable, excellent adhesive resin material. Now I will talk about the brief history of the bonding technology. As you know very well, in 1955, many years ago, Dr. Michael Bornocker published the paper on the enamel etching with the phosphoric acid for the bonding of the fissure sealant. It was very effective, but at that time there was no adhesive resin material. Dr. Ray Bowen in the United States, he tried to develop the adhesive resin monomer for the restorative treatment. But still, there was not the excellent adhesive resin material systems. In 1978, Dr. Takao Sayama, he published the paper on the total etching technique to both enamel and dentin for very good bonding of the composite resin material. By this uh, development, the so-called adhesive dentistry can be said to be started. And in 1993, another very innovative material was developed, that is the self-etching material, self-etching primer. Of course, even any case of the adhesive resin restorations, the removal of the smear layer is mandatory. If the dentin and enamel surface is covered by the smear layer, that is a cutting debris, we cannot obtain good bonding. Even if we can bond onto this surface, this smear layer is loosened and fallen off. So that's why we need some kind of surface treatment like phosphoric acid or the self-etching primer. In my department, we could collaborate with the Kurare Noritake Dental Company for many years. This is the first adhesive resin, Clearfield Bond F. The bond strength to dentin was very low, 2 megapascal. But at that time, in 1978, this was only the adhesive resin material for the restorative treatment. After that, the adhesive resin monomer was changed from phenyl P to MDP. By the development of the MDP, the bond strength became 2 times higher. Okay. At the time, people expected this kind of chemical reaction of the adhesive resin monomer and the tooth surface. Then after that, we had the light curing material, light curing catalyst. Because of the very good conversion, very good polymerization of the adhesive, we could obtain much higher bond strength. Then after that, we had the dentin primer, etching, priming, and adhesive. These 3-step systems provided us a very good bonding. However, these materials show the adhesive failure when we test the bond strength. Adhesive failure is the debonding between the composite resin and tooth surface. This is debonding. We say adhesive failure. However, in these material, that is the self-etching material, all the specimens show the cohesive failure of dentin. Dentin is broken. The debonding is not seen in the bonding specimens. So, the bond strength of this material is very high. The key monomer is the MDP. MDP is shown here. This is the carbon double bond for the polymerization, and this is the phosphoric part for the bonding. This is hydrophilic part, very important for bonding. And also this 10 alkyl chain is necessary to make this monomer as hydrophobic. Durability of the bond. So when we use this kind of adhesive resin monomer MDP, this phosphate part can be reacted with the calcium ion. This is a kind of a chemical bonding. That's why the bonding with MDP material is so excellent and durable. After that, the performance of MDP was confirmed comparing with other kind of adhesive resin monomers like format or phenyl Ps. The ability of chemical bonding with hydroxyapatite was the highest with MDP, and also the durability of that bonding in water was also the best with MDP. So that's why nowadays many of the manufacturers use the MDP for their adhesive resin material because the Kurare Noritake Dental Company kindly released the patency of MDP. Anyhow, the selection of the adhesive resin monomer is very significant factor for adhesive resin for good bonding. Now you can see this kind of development of the adhesive material. Then let's see the bonding mechanism to dentin at first. This is the old one, phosphoric acid etching and the bonding. This is the dentin surface, and the surface is covered with a smear layer, and this is a smear plug in the tubules. Okay, I can start the moving. Etching is done with phosphoric acid. This is very strong acid. Very quickly the smear layer is dissolved and the surface of dentin is demineralized. Then collagen layer exposed, and by drying it shrinks. Onto that surface, if you apply the bonding resin, the bonding resin cannot penetrate into these shrunk collagen layers. That's why this layer looks like the hybrid layer. However, there is a lot of naked collagen fibers without the penetration of the bonding resin. That's why the durability of the bonding was not so excellent. By the development of the dentin primer, in this product the dentin primer was here, SA primer. The bonding was very much improved. The function of the primer was seen with this kind of SEM photograph. This is in the case when we apply the primer. This is in the case without primer application. And this is the bond interface. This part is the bonding resin. This is the dentin. This is the dentin, and this is the bonding resin. And this is the original dentin surface. By etching, the surface of dentin is demineralized. And the surface of the hybrid layer is depressed in the case when we did not apply the primer, even though the collagen should have existed at this height. This is because of the shrinkage of the collagen layer by the drying procedures. The shrunk collagen layer produced this hybrid layer-like structure. However, the top surface of this hybrid layer is lower than the original dentin surface. On the other hand, in the case of the primer application, the hybrid layer formation can be seen here, and the top surface of the hybrid layer is equal to the original dentin surface. It means that the collagen layer did not shrink. They kept the original height of the structure. So that's why the primer is very effective to re-expand the shrunk collagen layers to accept more bonding resin into the demineralized dentin. That's why the durability was very good. In the case of etch and rinse technique with primer, I can show you. This is the smear layer, and etching is the same. The smear layer is removed, dissolved. collagen layer exposed, rinse and dry, it shrinks. But we have primer. The primer is effective to re-expand the shrunk collagen layers. Like this. Then we apply the bonding resin. Bonding resin can penetrate into these re-expanded collagen layers. However, unfortunately, the depth of the etching is too much. The phosphoric acid etching is too much aggressive. That's why there is still naked collagen fibers at the bottom of the hybrid layer. This part is a very weak point of the bond interface. So that's why the durability of the bonding with etch and rinse technique, even with primer, was not so excellent. This is the bond interface. This is the composite resin and bonding resin and hybrid layer and dentin. We immersed this specimen into the silver nitrate solution for one night. Then the silver penetrates into the microspace at the bond interface, and we try to detect the silver element on this scanning line. Now you can see the silver peak here. Even in the dentin, the bottom of the hybrid layer, you can see the high peak of silver, and also in the hybrid layer you can see the silver penetration. Also in the bonding resin you can see the silver penetration. This is the defect at the interface. This is believed to be the main cause of the degradation of the dentin bonding. When we evaluate the bond strength after the storage in water for 1 year, this strong etching material shows the debonding at the bottom of the hybrid layer. So we can say that the hybrid layer is a kind of a side effect of the etching. Of course, we should try to create the high quality hybrid layer. Now this is the Creative SE bond in 1999. This adhesive consisted of the two bottles. One is the self-etching primer, and another bottle is the light cure type of the adhesive bonding resin. Just two bottles. No phosphoric acid etchant, because the primer can etch the enamel and dentin because its pH was 2.0. This is acidic enough to etch enamel and dentin. The source of the MDP, the source of the acid, was the MDP. To make this solution acidic, we needed small amount of water. If there is no water, this MDP cannot be ionized, no acid. So that's why after we apply this self-etching primer, we have to remove the excess of the primer because it contains water. After that, we apply the bonding resin. Again, the MDP is involved, and other kind of hydrophobic monomers were included. Now you can see many kind of adhesive resin monomers by the manufacturers in the past time. Each manufacturer tried to develop their original adhesive resin monomers. But this MDP is very excellent. If you mix this monomer MDP into the aqueous solution, the monomer will be ionized. That's why the primer solution becomes acidic, and the surface of enamel and dentin is etched, and the calcium ion can be reacted with the phosphate part of the monomer. So I show the animation movie of the bonding mechanism with this two-step self-etching material. the self-etching primer is applied. This is acidic enough to remove the smear layer, but the depth of etching is not so deep, and the collagen layer is already treated with a primer, that's why it does not shrink. Then the bonding resin can penetrate fully into the demineralized dentin part, producing the very excellent hybrid layer without any microspace. That's why this bonding interface is very durable and strong. And about 10 years ago, of course, many clinicians and researchers were confused about the bonding material. In this paper, the bond strength results of the publications were directly compared according to the test method applied. This is the result. They compared the test method dividing into 4 groups, that is conventional shear bond test and the micro shear bond test and the conventional tensile bond test and the micro tensile bond test. In all test methods in the publications, the highest bond strengths were reported with this material. That is the Clearfield SE bond. This is the two-step self-etching systems. Because of this kind of analysis, this Clearfield SE bond was recognized as the gold standard of the adhesive. When we preserve the specimen in water for 1 year, even after 1 year storage in water, the two-step type self-etching material shows stable bonding, and the fracture mode at the bond interface was still in the material, not at the interface, not at the hybrid layer. Okay. Now this is the bond interface in the case of Clearfield SE bond. Composite resin is here, bonding resin is here, and very thin hybrid layer is observed. Even though the hybrid layer is very thin, the quality is very high, and there is no silver penetration at the bond interface. That's why this bonding is considered to be very stable, even after a long time. Now I can show the difference of the bond interface between etch and rinse type adhesive and self-etching type adhesive. The demineralized dentin and the defects are left with etch and rinse type adhesive, even with primer application. But the sufficient penetration of the bonding resin into the demineralized dentin was achieved with the self-etching type adhesive. So in this kind of situation, like a cervical restoration, this is the coronal part and this is the root side. When we prepare the cavity like this and apply the adhesive restoration, then we analyze the bond interface after the acid and base attack. Acid solution and the alkalic solution was applied to create the artificial recurrent caries, artificial secondary caries. Okay. So this is the original surface. Composite resin is here, and bonding resin is here. This part was the dentin. This is the tooth surface, and the interface is here. At this bond interface, we applied the weak acid and the basic solution to create the recurrent caries. That's why dentin was dissolved. That this is the depth of the artificial caries at the restoration margin. And you can see the margin here, very thin hybrid layer is observed, and adjacent to the hybrid layer, we still observe the dentin-like structure here. This dentin-like structure was resistant against the acid and basic attack. So that's why we named this layer as a superdentin. Superdentin was created with the excellent adhesive resin material applications. That's why in this kind of situation, the recurrent caries must be very well prevented compared to the other poor bonding interface. Okay, this superdentin was confirmed in the TEM analysis, and we published the manuscript with the term of the superdentin. I hope you can refer the paper afterwards. Now this is the superdentin. Okay, superdentin must be created along the bond interface beneath the hybrid layer. Sometimes this layer is said as the acid-base resistant zone of dentin. Okay, this is the bond interface of the etch and rinse type adhesive. A lot of defect is seen here, and this is the two-step type of the self-etching material. Composite resin is here, and bonding layer is here, and the hybrid layer, and the superdentin formation is seen here. Now, I hope you understand the fundamentals of the bonding. You can see that the penetration of the bonding resin is very important. And also, the penetrated bonding resin should be polymerized to create the very hard layer of the bonding resin. The penetration and hardening is very important fundamentals to obtain good bonding. To obtain good penetration, we need to apply some kind of acidic treatment like the phosphoric acid or self-etching primer application. And also, for the sufficient hardening of the bonding resin, we have to apply the sufficient light irradiation. Okay, but nowadays you may use this kind of one-step self-etching adhesive. And sometimes this is said as the universal bond, just one bottle adhesive. This one bottle adhesive material contains the so-called adhesive resin monomer, that is ionic resin monomers with phosphate or carboxylic functional groups. This is the acidic monomer. And also to make that bonding resin more hydrophilic, the monomers like HEMA is included. But after the polymerization, the bond layer should becomes hard layer. That's why hydrophobic monomers are also required, like bis-GMA and dimethacrylate and so on. And also to make this solution acidic, small amount of water is added. If there is no water, the solution cannot be acidic. The hydrogen ion cannot exist without water. Then to mix these hydrophilic material and hydrophobic material together, we need some organic solvent. So this is a very difficult technology. I show you the animation of the one-step self-etching. Onto the smear layer surface of dentin, the one-step self-etching adhesive was universal bond is applied. of course, it can etch enamel surface and collagen is exposed. However, unfortunately, before the polymerization, we need to remove the water and solvent because water and solvent cannot be polymerized. That's why we need to remove them. However, unfortunately, some of the water, some of the solvent must remain in the bonding resin and hybrid layer. That's why sometimes the bonding, in most times, the bonding performance of the universal bond was not so excellent as the two-step type of the self-etching material. Okay, now you can see that these recent adhesive resin materials showed very excellent bonding performance. The recent two-step self-etching material shows a 80 megapascal bonding to dentin. Even with one-step self-etching, one kind of universal bond, more than 70 megapascal. This is strong enough in the clinical use. However, if we know that this is better, I'm very happy to use it. Also, this is the weak point of the tooth, natural tooth itself. Many years ago, we evaluated the tensile strength at the enamel dentin junction with the very similar shape of the specimen like the bond test method. The result was 50 megapascal. Nowadays, the bond strength of the composite resin to dentin was much stronger than that at the tensile strength of the enamel dentin junction. So we can create it. We can create the very durable restoration and um, composite of tooth and composite resin. Now, as a summary, I can suggest these for the bonding. So I can tell you that the phosphoric acid etching cannot provide durable bonding to dentin. Of course, the enamel bonding is good, but for dentin, we should not apply the phosphoric acid etching. We should apply the two-step self-etching adhesives. In the case of one-step self-etching adhesive, like the universal bond, in this case, we should apply the phosphoric acid etching to enamel because the bonding of the universal bond to enamel was not sufficient. This is because of many kind of reasons, such as the difficulty of the removal of water and solvent and the difficulty of the polymerization. In the case of the two-step self-etching adhesive, it can be used as its original procedure. We can apply the self-etching primer to both enamel and dentin simultaneously, then dry the surface and apply the composite, the bonding resin and cure and apply the composite. And selective enamel etching sometimes improves its enamel bonding. But even in this kind of protocol, the self-etching primer should be applied to dentin, and however, it becomes a little bit complicated procedures. In most of the cases of my clinic, I use the two-step self-etching material as its original procedures. When most of the bonded specimen consists of enamel, I use selective enamel etching. Then I move on to the two-step self-etching. And also, phosphoric acid etching may etch the enamel dentin junction very drastically. So that's why In the case of selective enamel etching technique, I recommend to apply it at the enamel margin, curved surface margin of the enamel. That is good enough for the bonding. So in the application of this kind of material in the clinic, we mostly apply to the cavity in the tooth. So let's think about the bonding in the cavity. By utilizing the OCT, optical coherence tomography, we can observe the gap formation during the bonding and the restoration procedures without any invasive procedures. We can observe the real-time observation of the gap formation. It's very interesting. In this study, we prepared the cavity with a 2 mm depth and the diameter was 4 mm, consisted of enamel and dentin walls and the floors. And we apply the bonding procedure and we fill the cavity as a one bulk and we apply the light curing. Then we observe with the OCT. This is in the case of a kind of universal bond. After the application of the universal bond and the light curing, and we fill the composite resin as a bulk, as a one block. Then we apply the light curing. And if you see the white line along the cavity wall and the cavity wall, it indicates the existence of the gap. White line means gap. Okay, I will move it. Now light curing started to this, and look at this part. During light curing, of course, shrinkage of composite occurs already. Now you see the white line. The gap started mostly and extended to all the cavity floor dentin. Even after light cure stopped, still the shrinkage stress is remained in the composite resin. That's why sometimes the gap is extended. Okay. Now, like this, the gap is very easily created in the cavity. That's why we usually recommend the people to apply the flowable composite resin lining. We compare the gap formation between two groups, that is the flowable composite lining group and the no lining group. Then after that we confirmed it by the confocal laser scanning microscope. The result is very clear. These groups are the one-step self-etching adhesive universal bond. This is the two-step self-etching Clearfield SE bond. And light blue bar shows the cavity adaptation rate, percentage of the cavity adaptation with the group without the flowable composite lining. In one-step self-etching adhesive, some gaps, some debonding was observed with the one-step materials when we did not apply the lining. But when we apply the flowable composite lining, even with the one-step self-etching adhesive, there was no gap. Perfect adaptation was observed. However, in the case of two-step self-etching, even without the flowable composite lining, the bonding was very excellent. No gap observed. But in the clinical situation, the shape of the cavity is very much complicated. That's why even when I use the two-step self-etching material, I always apply the flowable composite resin lining like this. After the cavity preparation, we apply the bonding procedures and light cure to the bonding resin, and we apply the flowable composite resin lining and light curing. This light curing is also very important to apply the light irradiation to the bonding layer again. Because of this indirect light irradiation to the bonding resin, the polymerization of the bonding resin is much more advanced, and the good bonding is obtained. Then we can move on to the incremental filling of the composite to reduce the shrinkage stress of the composite itself. So that's why we should recognize these procedures, including the flowable composite lining, should be recognized as the bonding procedures. Then we can move on to the incremental fillings. Okay. This coating the bonding surface with the first layering of the flowable composite is very, very important and very effective. Now this is the clinical procedure of that. In Japan, people had a lot of cast inlay restoration, but nowadays people don't like this metal color restoration. The patient requested us to replace it with the tooth color restoration, and we removed it. We removed the cement and some kind of caries region. Then we can apply the bonding procedures. In this case, self-etching primer is applied to both enamel and dentin. Then after the removing the excess of the self-etching primer, because it contains water and sometimes solvent, then we apply the bonding resin and light cure. After that, we apply the flowable composite resin lining to the bottom of the cavity. And also I apply this flowable composite lining to the cavity walls together. We spread that flowable composite with explorer like this, and after the light curing, we can apply the paste type of the composite resin, incremental filling technique. Filling and light irradiation, and filling, light irradiation. We repeat these procedures. Then this is after the treatment. Nowadays, we can complete this kind of restoration with only the flowable composite resin material. In my country, the very high mechanical strength flowable composite resin is available, and it's very easy to apply the anatomical form of the tooth itself, and its clinical performance is very excellent. So that's why in my second lecture next week, I will talk about the keys to obtain the success with the posterior restoration as well as the anterior restoration, especially the aesthetic restoration with direct composite resin restorations. Also, I'm very happy to introduce my 40 years clinical cases and other very long period clinical cases, more than 20 years using many kind of composite resin for various applications in the clinical situation. But By understanding this kind of bonding materials and the composite resin materials, we can apply those materials to the new clinical cases. We should not follow the established procedure of the restoration anymore. We can create the new new direct composite restoration to various kind of problem of our patient. Patient has different kind of problems, and for each clinical problems, we can try to apply the recent material for solving those problems. I hope you can enjoy today's topic on the adhesive dentistry, and so I hope you can attend my next lecture, and I hope to see you again. I thank you very much for your very kind attention. Thank you very much, and I'm very happy to have your comment and opinion and questions. I hope the moderator will take care of your questions. Thank you very much. Hmm. Okay, um, I already have two questions. I can try to answer now. May I talk? Okay, I think I can talk. I can answer to this question. The first question is, what do you think about the use of chlorhexidine to deactivate MMPs? Nowadays, the MMPs is uh, not recognized as the important factor for the degradation of the dentin bond interface, and it was mostly it was mostly the hypothesis, the theory created by the hypothesis. But in fact, the MMP exists intrinsic of dentin, and it may be activated in many kind of stimulations. And anyhow, the MMP can be um, deactivated by the chlorhexidine and also by fluoride and many kind of substances. So that's why at first I don't trust the function of MMPs for the degradation of the dentin bonding in the clinical situation. And also uh, such a complicated procedure for the bonding may not be recommended in the clinical situation. In the clinical situation, the simplified bonding procedure should be recommended to, to prevent some kind of technical errors. Okay, I hope this answer uh, is to the first question. And the um, what do you think about using the universal bonding agent in multiple applications to increase its thickness? Yes, um, universal bonding agent tend to be very thin if you apply it because it should be thinned. It should be thinned before the polymerization. Because of its thin layer of the bonding itself, the polymerization is not so excellent. That's why it cannot perform the high bond strength immediately after the application. That's why it may easily cause the debonding in the cavity floor. That's why after the application of the universal bond first and apply the light curing, and again you should apply the universal bond again and apply the air blasting to remove the water and solvent and apply the light curing. Then the thickness of the bond layer becomes uh, thicker. But this is also a very complicated procedure. Even after that duplicated application, double application of the universal bond, you should better to apply the flowable composite lining. Flowable composite lining can cover the surface of the bonding layer, and on the surface of the bond layer, oxygen inhibition layer is not created anymore. That's why the polymerization of the bond layer is very excellent. But it's very much complicated. And still, the bond quality is much better with two-step self-etching adhesives because in the case of two-step self-etching system, the bonding resin itself does not include any water, any solvent. It's the bonding the resin monomer, including hydrophilic monomer and hydrophobic monomer, and also sometimes small filler particles involved. That's why the bond layer becomes very strong, and also the thickness of the bond layer becomes a little bit thicker. So that's why the bonding is very excellent. Even with two-step self-etching, I recommend to apply the flowable composite resin lining. Okay. Um, Also, the third question is that will you talk about injection molding technique? Yes, injection molding technique was very recently established in my department, and also there are some clinicians and researchers doing the similar injection molding technique using the silicone core indicator, silicone core materials. Uh, Sometimes people use the trans translucent, transparent, clear type of the silicone material is used. In that case, you apply the clear type of silicone core in the tooth and in the mouth, and you can apply the injection of the flowable composite, and you can apply the light from the outside of the clear type of the silicone material. That is also very useful and a very interesting procedures. That technique is very useful, especially in the case of the direct bridge restorations. However, we still have some problems because we have to polymerize the very big amount of the composite resin at one time. That's why the shrinkage stress is not controlled so well. In the case of the injection molding technique, the bulk filling type is not so much easy. And but um, it, for in many of the cases, we apply the silicone core indicators, and we apply the flowable composite, not like the injection, but we just uh, build up with a wax cone technique. We can utilize the surface tension of the flowable composite, and it's very easy to create the anatomical form of the tooth. So many kind of the idea is applied for the application of the flowable composite resin material. In next week, I try to add some clinical slide of the injection technique. Okay, thank you very much for your suggestion. Any questions? please feel free to ask any question. I enjoy clinic with adhesive material, and I always have some problems. So that's why I'm very happy. I enjoy very much about the research to solve those kind of clinical problems. Okay, no new questions anymore. Okay, okay. Um, I thank you very much for your very kind attention and very good discussion. Uh, I hope you enjoy the adhesive dentistry, and of course, um, your your skill and your technique must uh, save your patient, and your patient must be very happy to have the minimally invasive approach with the maximum aesthetic result of their tooth. Thank you very much. See you again.